Welcome all of you. This is Mumbai Pain School's Pain Journal Club. We'll just start in a moment, and I'm going to just share my screen now. So I hope all of you can see my screen now. So please type yes in the chat box if you can see my screen. Great, I'll make it full screen now. Yeah. Okay, so guys, this is the 72nd Pain Journal Club, and today we are going to dwell on a very important topic, which is inflammatory arthritis. And this is the MSK Ultrasound themed Pain Journal Club for the season 4. And I'm going to just start with the basic introduction. So pain medicine world over has got a lot of different issues. It has got diverse trends, variable standards, and different learning requirements, different offerings, and money and time is something which prevents the physicians from learning about this wonderful branch. So I think this is very clear. To overcome this all these issues, Mumbai Pain School has been started as an initiative of Panisha Spine Wellness and Pain Relief Center, and we are mostly focusing on online education, and uh, of course we have our offline events as well, and we got tremendous response online on various platforms like Facebook, Instagram. Most of our content, as I mentioned, is online. It's on demand, and most of this is free to everybody. But we also have paid content, and we conduct our workshops, which is regularly being attended by participants from all over the world. So guys, we have expert faculties also who are helping us from all over the world. It's said that the best teachers, they teach from the heart and not from the book. What's a club? Journal club is nothing. It's just a club. The only difference is that here we discuss and critically evaluate the recent academic literature, which is based on a very defined subject. And attendee participation is extremely important to us, and I encourage all of you to participate in the journal club by asking questions, giving comments and suggestions. Critical appreciation or critical evaluation is also welcome. So it's very tough to be regular, so try to be regular. I always see new faces each time. Even Harrison used to conduct his journal club for critical evaluation. Time and discipline is very important for the success of the program, so I request both the speakers to remain in the time limits. Healthy skepticism or praise is most welcome. This is a bit about me. I am a pain physician practicing in Mumbai. But today we have with us distinguished faculties. Dr. Aneesa Kapadia, she's done her DNB General Medicine uh, as well as MRCP from UK, and she's done a special training in rheumatology. She's a consultant rheumatologist and visiting consultant at various hospitals, various famous hospitals in Mumbai. She's trained at the Department of Rheumatology at the Nottingham Nottingham University in the UK, and she has done her specialty certificate examination in rheumatology, as I mentioned. You can visit her at draneesakapadia.com. So I think she's joined. I'll just make her the co-host. Yes, I found you. So welcome, Dr. Aneesa. You can unmute yourself and say hi to
Yeah,
everybody.
hi, hi, hi,
Welcome.
yeah, hi. So
Yes.
I'll just be on mute and
Yeah, sure. Sure.
let me know whenever we need
Sure.
the
Sure.
introduction.
Sure. Sure. Great.
Okay,
Great.
yeah.
Welcome. So we also have with us our second faculty. He's Dr. Akhil Bhalla. He's done his MD, FIPM, FIPM, and he's currently working as assistant professor, and he's the in charge of pain medicine at Department of Anesthesia and Pain Medicine at Adesh Medical College in Ambala. He is founder and consultant of Pinnacle Advanced Pain Management at Chandigarh. He is also the visiting interventional pain consultant at multiple hospitals in Chandigarh Tri-City area. Dr. Akhil, you are here.
Hello, sir. Yes, sir.
Yeah, hi.
Um,
Hi.
Good
So I
evening, sir.
think good evening. So you are very well dressed. I think it's quite cold there, right?
It is, sir. It's chilly, I guess.
Yes. Okay. Okay. So welcome both of you. Now we go to the presentations. I'll request Dr. Sasmit to start sharing his screen. Dr. Sasmit, just put up your CV slide and I will introduce you. So yeah, you can make it full screen.
Yeah. Is it visible, sir?
Yes, it is visible. Can you put in
Yes.
the next slide? Yes, so Dr. Sasmit Lotliker has done his MD and FIPM from Patil University in Mumbai. He is consultant interventional spine and pain physician at Manipal Hospital, Borkar Hospital, and Menzies Hospital in Goa. He's also the director of Thavasmi Spine and Pain Clinic at Goa. So over to you, Dr. Sasmit.
Thank you, sir, for the introduction. Good evening, everyone. So today I'm going to present this paper, The Role of Musculoskeletal Ultrasound in Rheumatoid Arthritis Continuing. This is a review article which was published in the Current Rheumatology Reports in 2020 by Andrea Di Matteo, Kulveer Manika et al. At the Leeds Institute of Rheumatic and Musculoskeletal Medicine, Leeds, UK, National Institute of Health Research, Leeds, Department of Clinical and Molecular Sciences, Italy, and the Department of Orthopedic Surgery in Japan. Coming to the introduction, rheumatoid arthritis is no longer considered a fixed phenotype, but is rather a disease continuum. In 1997, at the American College of Rheumatology conference, questions were being raised regarding the utilization of ultrasound in rheumatology. Ultrasound in rheumatology improves the accuracy of physical examination, enables a deeper understanding of the joint pathophysiology, as well as it provides the means of guiding needles for interventions. Over the years, we have seen improvements being made in the image resolution through greater processing capabilities of computers and the development of higher frequency transducers. Doppler modalities also enable the depiction of tiny anatomical details which are less than 0.1 mm resolution, as well as blood flow. In rheumatoid arthritis, ultrasound is able to detect the signs of acute inflammation such as synovial and tenosynovial effusion, synovial hypertrophy, power Doppler signals, or soft tissue edema, as well as structural damage including bone erosions, loss of cartilage, or tendon tears. Real-time comparison is also possible of the anatomical findings. So this is a figure of a longitudinal scan of the tenosynovitis of the third flexor tendon, digitorum tendon. As we see here above, this arrow depicts the synovial effusion over here, whereas this here arrow depicts synovial hypertrophy. This is also a longitudinal scan of the second metacarpophalangeal joint in a patient with rheumatoid arthritis. If we see here, these are the bony erosions which have been depicted in the ultrasound scan, whereas here we can see the synovial hypertrophy in this patient. Coming to the aims and objectives, so to outline the current and potential value of applying ultrasound for the prediction of progression to rheumatoid arthritis in at-risk individuals, confirmation of early diagnosis of rheumatoid arthritis, as well as the consideration of differential diagnosis, and disease monitoring and defining remission. Coming to the utility of ultrasound for individuals who are at risk of rheumatoid arthritis without any clinical synovitis. So this is the preclinical phase of rheumatoid arthritis or pre-rheumatoid arthritis, as we say. patients who are considered at risk of developing rheumatoid arthritis, but they have not yet developed the clinical synovitis. These are patients who have positive autoantibodies with symptoms such as fatigue and clinically suspect arthralgia or CSA, but without any signs of clinically detectable inflammation. They may have underlying genetic and environmental predispositions such as first degree relative or cigarette smoking. In the absence of any such guidelines for this patient, management of this symptomatic at-risk patient becomes challenging and is highly variable. Now, the ultrasound findings in at-risk of rheumatoid arthritis patient will improve our understanding of disease pathogenesis as well as help in better risk prediction and stratification for interventions. An observational study by Stack et al. For early rheumatoid arthritis-related inflammation shows that it occurs outside the joint capsule as evidenced by redness and edema of the skin prior to the onset of rheumatoid arthritis disease. The involvement of these extra-articular structures explains the prodrome of non-specific pain and stiffness which will precede the clinical synovitis. Ultrasound detected subclinical inflammation and joint damage, that is bone erosions, along with clinical and serological biomarkers have been added as variables in risk prediction tools for anti-CCP positive individuals who are at risk of rheumatoid arthritis. Now, this is a table which shows ultrasound in the utilization of rheumatoid arthritis continuum. If we see at the left-hand side of the corner, individuals who are at risk of rheumatoid arthritis with positive autoantibodies with MSK symptoms but without any clinical synovitis, ultrasound will help in detecting subclinical inflammation and or joint damage as seen by bony erosions. It will also help in predicting the development of persistent arthritis, that is mostly rheumatoid arthritis. This will in fact help in predicting the development of inflammatory arthritis and improves the risk stratification and management. Also, it will improve the early diagnosis and treatment, which gives us a window of opportunity for the better treatment. Now, patients with early undifferentiated arthritis, again, if ultrasound will help in predicting development of persistent arthritis, mostly rheumatoid arthritis, and also in improving the early diagnosis and treatment. Along with this, it also helps in the differential diagnosis with other types of arthritis, such as psoriatic arthritis, and this also will help in early diagnosis and treatment of these conditions. Coming to patients who have got established rheumatoid arthritis, ultrasound will help in assessing the response to therapy and evaluation of new symptoms. It also, by integrating ultrasound into the clinically centered monitoring strategy for guiding treatment management. Those individuals who are in remission according to clinical instruments, ultrasound will help in detecting subclinical inflammation and thereby helps in predicting the progression of structural damage and disease relapse after the treatment tapering. So, coming to the use of optimum use of ultrasound in individuals who are at risk of rheumatoid arthritis. So, subclinical inflammation detectable by ultrasound is likely to be a late feature in development of inflammatory arthritis, and serial ultrasound assessments in a cohort of anti-CCP positive at-risk individuals will suggest subclinical inflammation who develop directly before the clinical synovitis occurs. Ultrasound may not be as informative in low-risk individuals who do not yet have imminent clinical arthritis, and significant risk of overtreatment is there for most symptomatic as-treated patients may not go on to develop the clinical synovitis. Also, if the treatment is initiated on the basis of ultrasound findings, there may be little consideration which is given to therapeutic regimen, and patients could become unnecessarily committed to long-term use of drugs. Also, it is not clear which joints and indeed how many joints need to be imaged for optimal predictive accuracy. Coming to ultrasound is the confirmation of diagnosis of rheumatoid arthritis. So, diagnosis of rheumatoid arthritis is mainly a clinical diagnosis. The presence of synovitis and rheumatoid arthritis-related bone erosions are important components, as seen in the 2010 ACR Euler criteria for rheumatoid arthritis. Both these criteria have acknowledged the potential value of additional imaging such as ultrasound to confirm the presence of inflammation. However, they state that information gained from the ultrasound can only be used if clinical synovitis has been confirmed in at least one joint. Value of ultrasound for diagnosis of rheumatoid arthritis lies in its ability to confirm the presence and extent of inflammation and its sequelae. A study by Frester et al. Evaluated the value of power Doppler signal in combination to routine clinical examination, and they found that at 12 months, 47% of the patients had developed rheumatoid arthritis, whereas 22% did not develop any persistent arthritis. Another study by Sabuddin et al. Also evaluated the value of ultrasound for tenosynovitis, and they found that tenosynovitis of the finger flexor tendons resulted in an independent factor for prediction of rheumatoid arthritis over and above the presence of anti-CCP positive antibodies and synovitis on ultrasound. Coming to ultrasound is a differential diagnosis for RA. So once the diagnosis of synovitis has been established, ultrasound will then have a potential role in the differential diagnosis. A study by Gutierrez et al. Evaluated the value of the ultrasound in differential diagnosis between rheumatoid arthritis and psoriatic arthritis, and they suggested the presence of inflammation on ultrasound at specific anatomical sites is a higher characteristic of psoriatic arthritis. Identification of extracapsular inflammation on ultrasound is having a potential value for differentiating the RA from other rheumatic conditions such as palindromic rheumatism and SLE. The accessory pulley, which is linked to the flexor digitorum tendon, has emerged as a specific potential target for the musculoskeletal involvement in patients with psoriatic arthritis. In a study by Tinazi et al., they observed the accessory pulleys are thickened in subjects with psoriatic arthritis as compared to rheumatoid arthritis. Also, the presence of large erosions in selected joints such as second and fifth metacarpophalangeal joints, distal ulna, and the fifth metatarsophalageal joint were highly specific and predictive for rheumatoid arthritis. Coming to a double contour sign, this is an abnormal hyperechoic band over the superficial margin of the articular hyaline cartilage, which may be either irregular or regular and is continuous or intermittent. This was defined by the latest outcome measures in rheumatology or OMEREC. It represents the most representative ultrasound finding in patients with gouty arthritis as seen by the ACR Euler classification. Now, in this diagram, we can see this is a longitudinal scan of the second metacarpophalangeal joint, and this here is the double contour sign which is seen. The arrow marked here shows a large bony erosion suggestive of monosodium urate crystals, which are typical of gouty arthritis. Coming to ultrasound in the monitoring of patients with rheumatoid arthritis, in a study by Naredo et al., they evaluated 42 patients with early rheumatoid arthritis and was started on conventional DMARD treatment. Synovitis was seen on ultrasound and defined as a combination of grayscale and power Doppler signals, which improved in accordance with the clinical parameters at 12 months follow-up. Another study by D. Agostino et al. Evaluated patients with rheumatoid arthritis who were not very responsive to methotrexate, and significant improvements were seen in disease activity indices as well as ultrasound findings in these patients. Now, which patients would actually benefit most from ultrasound scans? Patients with a long-standing disease who develop new symptoms, patients who are not responding to therapy. So, if ultrasound detects no features of rheumatoid arthritis, this may allow the clinician to consider an alternative diagnosis. Patients with significant subclinical disease at baseline, which is highlighted by a substantial mismatch between clinical and ultrasound examinations. Coming to the utility of ultrasound in clinical remission of rheumatoid arthritis. So the observations on remission was that prognosis and outcome of patients with rheumatoid arthritis have actually improved drastically, and the number of RA patients who are achieving clinical remission has grown exponentially. This is being attributed to early diagnosis as well as the application of the T2T strategy of the ACR Euler recommendation and the improvement in the therapeutic armamentarium, that is by the advent of biological DMARDs. Disease activity in patients with rheumatoid arthritis as assessed using clinical instruments such as the DAS28 erythrocyte sedimentation rate or clinical disease activity index is also being made. Now, what is the role of ultrasound in detecting subclinical synovitis? In a longitudinal study by Brown et al., it was observed that significant association was present between subclinical inflammation of ultrasound in a particular metacarpophalangeal joint and the presence of bony erosions in that same joint. Also, another prospective observational study of 125 patients who were treated with TNF alpha inhibitors showed a greater power Doppler signal more than grade 1 and near to the bone surface. But a recent prospective study of 383 patients, however, showed no significant difference between the clinical outcomes. Coming to predicting outcomes of treatment, that is tapering or discontinuation in rheumatoid arthritis, data from RCTs, registry-based and observational studies have shown the status of treatment-free clinical remission is obtainable target in some patients with rheumatoid arthritis. However, some studies show that rheumatoid arthritis patients flare when the therapy is either tapered or discontinued, with significant impact on the quality of life and possible joint damage progression. And few studies have demonstrated the presence of ultrasound subclinical synovitis in RA patients in clinical remission, which represent a predictive factor for the disease flare after the treatment tapering or discontinuation. So there have been two recent RCTs, TESSER and ARTIC, which have demonstrated that a treatment strategy which was based on ultrasound assessment did not lead to any improved clinical outcome in comparison with the conventional T2T approach. To conclude, so this review has highlighted current and potential utility of ultrasound imaging across the RA continuum, its ability to identify early inflammatory and structural changes in joints and soft tissues, early diagnosis and prediction of the outcome through risk stratification and ensuring optimal disease control. Ultrasound also allows for newer insights into understanding joint pathology as well as in helping in differentiation between the diseases. The limitations accepted were more efforts are needed to overcome the intrinsic as well as well-known limitations of ultrasound such as high operator dependence and consequent large inter-operator variability. Also, further longitudinal studies are required to validate the possible predictive value of the ultrasound finding for successful DMARD tapering or discontinuation in RA patient in clinical remission. So coming to the critical analysis, more RCTs and systematic reviews have to be considered, and the need to identify optimum number and site of joints to be assessed for risk prediction. So ultrasound has a great utility across rheumatoid arthritis continuum, and it can play a key role not only in the diagnosis of rheumatoid arthritis, but also in the differential diagnosis, monitoring of patients with rheumatoid arthritis, as well as predicting the treatment outcomes, and also to detect at-risk patients. Thank you.
Thank you, Dr. Sasmit, for the excellent presentation. We'll take the questions now because Dr. Aneesa has to go somewhere. So I think we do the questions if there are any for this. So I think Dr. Akhil and Dr. Aneesa, you can take the questions now. If you have any questions, comments, or whatever, we can make, and this will be the right time. So right now there are no audience questions. Usually we take the questions at the end, but
Sure.
anyway, we can take if there any questions. Sasmit, do you want to ask anything, or do you want to if there anything is there, we can just discuss now. Dr. Akhil, over to you.
Okay, so Sasmit, if you want to ask a question, or I'll ask ma'am. So, ma'am, I have a question for you.
Yeah,
So,
sure. Please go ahead.
So, ma'am, what would you do in your practice when you encounter a rheumatoid arthritis patient, and especially when the patient has been termed as a remission patient, which we usually
Right.
see when they come to our OPDs, they have usually come with a flare-up, and
Yeah.
they are usually sent by rheumatologists for an interventional pain.
Factorial, we understand that. But first and foremost, if someone is diagnosed as rheumatoid arthritis, our first goal would be to identify if there is, as Dr. Sasmit has already rightly pointed out, subclinical inflammation that we can't clinically see. So not only in rheumatoid patients, but especially in psoriatic arthritis, psoriatic spondyloarthropathies, and the seronegative categories, patients have all these soft signs like enthesitis or tendinitis, which is not clinically always visible. So I think in those, especially in these categories, ultrasound is very, very useful. And even the patients who have early RA, I think ultrasound is the most useful in those patients. And we routinely use it to identify the mild disease activity, low disease activity, and then we can justify increasing the immunomodulation in these patients before we sort of subject them to a procedure. Because at the end, you subject them to a procedure, maybe one joint gets better or one part of the body gets better. But as long as we control the disease activity, you're not going to get great results. So that's how I look at it. But of course, I mean, every patient is different. So I think individual cases would, be different.
Sure, ma'am. I totally agree to the treat to target approach that has been given in the recent guidelines.
Totally. So that has really changed over the years. And I think depending on also sort of what philosophy you belong to, the treat to target approach is where we accept absolute remission can only be when the patient is absolutely pain free and free of any mild inflammation also.
Yeah. So I think that is where these papers come handy, because they were a very good read, and they suggested that even a subclinical infection might be missed, and a subclinical, so they might flare up later.
Absolutely. So I have practiced in ultrasound clinics in the UK, where ultrasound is very much a part of routine practice. It's part of rheumatology clinics. So bedside, if a patient complains of pain, we would scan the patient there and then to see if, what is the degree of inflammation. So you can take a decision to step up the immunosuppression immediately. Now that is not possible in India because of multiple reasons. But maybe mainly because of the legal implications of having a license for ultrasound. But I mean, everywhere else, and especially in UK, Europe, ultrasound is very much a part of routine practice now.
Great. So I think maybe like most of the pain physicians will have the access to ultrasound in their places. So I think they should start doing more and more, and probably
Definitely, yeah.
trying to
And I think the papers are very good, very well selected because they not only talk about the RA, but they also talk about the other disease entities like psoriatic arthritis, enthesopathy, PMR. There's so much indication for ultrasound. I don't think we are utilizing it enough as of now.
yes, so that is quite underutilized. I also feel the same.
Yeah.
Great. So any other comments, Dr. Aneesa, you would like to make, or Dr. Sasmit, Dr. Akhil? Because right now there are no more questions, I think. So otherwise we move ahead. There is
Sure,
one.
we can go ahead. I'm there for some time, so I'll try and hang on to the end of the second paper.
Great. There is one question which is come up. This one is from Facebook. Somebody is asking. Okay, this is a intervention related question, so I think we can take this in the end as well. They're asking about
Sure.
gout pain, what kind of intervention they want to take. So we'll take it together in the end. Okay, so thank you. Now we move on Dr. Namrata's presentation. Dr. Namrata, now I'm just making you the co-host. And you can just start sharing your screen, and then we can go on from there. Okay. Yeah, please, you can start sharing your screen now. Yeah, can you put your CV slide so that I can just introduce you? Yes, so Dr. Namrata Bhagwat has done her MD in anesthesiology, and she's a practicing pain physician. Dr. Namrata, can you put your previous slide? Go back to the CV one. Yeah. She's a consultant pain physician at the Vatsal Pain Clinic at Akola, and she's also a consultant pain physician at Sant Tukaram Hospital, Akola. And she focuses on the importance of ultrasound in identifying and differentiating patients with early arthritis in this, I think, paper. Great. So over to you, Dr. Namrata. You can make it full screen, and then go on from there.
Is my screen?
Screen is visible, and now full screen is audible. Yes, you are audible.
Okay. Yes.
I think just click on the screen once, then you'll be able to move.
Yes. Okay.
Yes,
So,
we can see the screen.
this is a review article. So this is a review article. It states the importance of USG in identifying and differentiating patients with early inflammatory arthritis. So it was published in Arthritis Research.
So sorry to interrupt, Dr. Namrata. You are very your voice is kind of breaking in between. So can you?
Breaking?
Yeah. So can
Okay.
you shut your video off? The video button, probably that will improve it.
Yes.
Maybe there is some bandwidth issue.
Yes.
Just try that.
Yes.
If that
How about
improves.
now? How about now?
Please continue speaking. If I can't
Yes.
hear you.
Okay.
Interrupt.
So the authors are Guru Kylie, Akhil Bhalla, and User. Now,
Yeah, it's just kind of wavy, very wavy, like it coming and going.
let it just refer to some other internet. Please.
Sir, it could be a Bluetooth delay. You can switch off your Bluetooth earphones if she's on that.
Yes, I am on Bluetooth.
Yeah, just
So shut
cut
off your Bluetooth.
cut the
Maybe on the
Bluetooth.
directly you can.
Okay.
Because otherwise you can't comprehend. difficult.
Am I audible?
Yeah, much better. Please go on.
Yes. So,
Yeah, much better.
okay.
Go on.
Yeah. So, the aims, the authors were Gurjit Kaili, Catherine Bakewell, and Atul Devdar. It was studied. The study was conducted in Division of Rheumatology and Clinical Immunology, University of Florida, USA. The aims and objectives of this study, they were: first, to find out the importance of imaging to differentiate between inflammatory and degenerative arthritis, especially when clinical signs are sparse and the serologies are negative. Then to find out the use of USG in the DDs of early inflammatory arthritic phenotypes and to assess any important limitations of the technique. Introduction. Inflammatory arthritis affects an estimated about 115 to 271 people out of 1 lakh adults. Symptoms are joint, tendon, or enthesial inflammation. These could be short-lived or persistent. If persistent, they can lead to permanent skeletal damage, which leads to morbidity and disability. Early treatment with targeted therapies can alter long-term outcomes. It prevents joint damage and disability and hence improves the quality of life. Now, the routine to establish presence of arthritis is history, physical examination, labs, and X-ray. But then it becomes challenging when all of these become ambiguous. So what are the challenges? Symptoms, all of them might have joint swelling, erythema, morning stiffness, radiographic evidence of bone loss around joints. The number and type of joints and pattern could also be similar. Enthesitis and dactylitis in obese patients could be challenging to detect. Now, if the serology could be inconclusive, acute phase reactants could be non-specific, early and milder disease, then only imaging could help. So imaging, we have CT, MRI, and USG, of which USG has many positive points over the other two. Now, the subclinical synovitis, asymptomatic enthesial inflammation, bone erosions, and crystal deposits which could be otherwise missed on physical examinations, can be detected by USG. Now, USG is already included in 2 most recent EULAR and American College of Rheumatology classification criteria for PMR and gout. Use of USG in diagnosis and DD. Why? Because it can generate high resolution. It can be imaged in dynamic fashion while movement, like to visualize the synovial changes, the effusions, the tendon movement, the tears, and bone erosions. Power Doppler can help us assess the soft tissue lesions, nerve lesions, the vascularization, and the hyperemia of the structures. Then to differentiate trauma-related injuries which mimic the inflammatory arthritis, like subluxations, occult fractures, the tendon ruptures. Again, why USG? So we all know point of care, convenient, non-invasive, cost-effective, examination of musculoskeletal structure is possible. And when MRI is contraindicated, then it's a boon. So early arthritic, now if a patient comes and the patient has early arthritis with swollen joints, pain, stiffness, and the clinical evaluation is unable to fully characterize this. So now it becomes undifferentiated arthritis. So here the USG can help. So if there's high suspicion, subcutaneous edema is there, positive Doppler should prompt aspiration, and positive synovial fluid culture will establish the diagnosis. Here the clinical suspicion matters a lot. Now, enthesitis, palmar plate inflammation, collateral inflammation can diagnose spondyloarthropathies. Similarly, age and the joint which are scanned, like bilateral shoulder, hip, these can lead to PMR. Then in the syndrome where synovitis is present, in such cases, thus if there is symmetric joint distribution, could be RA, asymmetric joint distribution, double contour, atophy, then it could be gout, then chondrocalcinosis, tendon calcification, CPPD, and then there could be some overlap syndromes which might help us to diagnose a few things. Again, regions that may be initially prioritized are, so now if we compare these 4, so we'll see that all of them have wrist, the wrist joints are involved. Now, if we refer this table and find out that these are particular joints which could be scanned to find particular sonopathologists, respective sonopathologists as per the table, so that we could reach closer to a diagnosis. For septic arthritis, the clinical suspicion is highest, gets highest marks, and the aspiration has to be done. Now, the paper discusses the characteristics of USG appearance in B mode, depending on these 5 criteria. So, synovitis and tenosynovitis, enthesitis, bone erosions, crystal deposits, and older patient issues. Now, we'll first just clear like how to find out whether our machine is sensitive enough to hypervascularity. So as to avoid false negative testing. So this is a scan where there is a finger has been scanned with a USG probe, and now Doppler signal in more than 1/3 of finger indicates there's a reasonable sensitivity of the machine, and the settings are enough to pick up hyperemia. This helps us avoid false negative testing. So synovitis and tenosynovitis. Synovitis will present as abnormally thickened, hypoechoic or anechoic, non-displaceable and poorly compressible intraarticular tissue. And this proliferation could cause disruption of articular cartilage and erosions. Tenosynovitis, same kind of lesion, but with or without fluid, but in the tendon sheath, although this is not specific enough. Wherever there are sonographic signs of synovitis, it should prompt the use of Doppler to look for vascularity. These are some images given in the paper. So here we can see there is synovial proliferation around this tendon. This is the transverse view, and then in the same longitudinal view, there is again synovial fluid around the tendon. Again, on Doppler, there is the in the extensor tendon there is high vascularity. Similarly, this is for the dorsal proximal interphalangeal images, which show synovitis in the recess marked by asterisk. Here there's increased vascularity. How USG made a difference in some cases? So in some cases where there was oligoarthritis, when USG identified synovitis in even the asymptomatic joints of patients, the diagnosis from oligoarthritis, that is the reclassification from oligo to poly, was possible. And in patients who were arthralgia but not diagnosed inflammatory arthritis as such, and then in them there was absence of USG detected synovitis. So it had a high negative predictive value, around 89% of development of arthritis over 1 year. So USG was correct in that. Again, USG in enthesitis, what all can be visualized? Subclinical enthesitis. Then it has helped demonstrate that nail disease in psoriatic arthritis and psoriasis is associated with distal interphalangeal enthesopathy. It can detect ecotexture changes. It can detect perienthesial Doppler signal. Then even the adjacent tissues can be scanned for pathologic changes. Severity of sonographic enthesitis, it correlates with peripheral and axial joint damage. Sites most, it is controversial, but these are the most accepted sites. That is the Achilles tendon, the quadriceps and patellar tendons, and the plantar fascial enthesis. On Doppler, vascularization at the cortical bone insertion. So this, when found, makes it easy to collect data as well as score the disease so as to approach a particular diagnosis. Then adjacent bursitis and tendon calcification can be observed. So these are enthesophytes. This is at the Achilles tendon, and these are at the patellar tendons. Now in bone erosions, so bone erosion is an important hallmark of both RA and SPM, spondyloarthropathies. This is based on the intraarticular discontinuity of the bone surface, which is visible in two perpendicular planes. It accurately identifies cortical irregularities of at least 2 mm with breaks in the bone surface associated with the inflammatory arthritis. And again, more visible in detection of bone erosions in superficial joints like hands and toe joints rather than the carpal and tarsal bones. Larger erosions, now if there is larger erosion at the second and fifth metacarpal joint or the fifth metatarsophalangeal or the distal ulna, then diagnosis of RA was likely. RA patients where the power Doppler synovitis activity and clinical activity showed well controlled. But in such cases, if there was detection of bone erosions after the discontinuation of the MRDs, this was a risk factor for relapse. So here USG helps to find out relapse or to monitor the therapy as told in the previous lecture as well. Caution to be exercised for false positive findings, typical at some sites. Now because a study found out that joint erosions were found in 91% of RA, 90% of gout, 75% of spondyloarthropathy, 70% of osteoarthritis, as well as 33% in healthy volunteers. So one has to exercise caution. In gout and the crystal arthropathies, so USG can differentiate the chondrosynovial deposition of urate from the intracartilaginous chondrocalcinosis. Again, then there are now in patients with arthralgia, recurrent episodes of arthralgia, when USG was done and clinically undetectable tophi were found in soft tissue and tendons. These helped in diagnosing the patients as gout. In CPPD crystal deposition disease, again, same tendon calcifications, multiple joints could be found. So hyaline cartilage and fibrocartilage of the knee is most frequently involved. Now, again, where we have to aspirate for the crystal analysis, USG plays a vital role for the needle placement and location. USG is sensitive to changes in gout and can be used to monitor the tophi burden. These are the images where tophi, so in the upper image, we can see bone erosion. And in the B image, we can see the chondrosynovial urate deposition. Again, here we can see the tophaceous deposits around the joints. Here, we can see calcium pyrophosphate deposition. Same images magnified here. Now in PMR, polymyalgia rheumatica, in older patients with shoulder and hip pain, a diagnosis of PMR should be considered. In them, there are some sites like bilateral subacromial, bilateral subdeltoid bursitis, long biceps tendon tenosynovitis, trochanteric bursitis, and glenohumeral and hip effusion. A systematic review has found that bilateral shoulder bursitis on USG had the highest specific of any individual finding on PMR. So these sites should be looked when the suspicion is high. Now, some cases may there may be a conflict between polymyalgia rheumatica and elderly onset RA. In such cases also, USG could be of help. So absence of synovial proliferation at the hand or wrist on USG could be suggestive more of PMR than elderly onset RA. Then negative serologic testing for CCP antibodies and for RA could also help us rule out the diagnosis of EUR. Limitations: USG is unable to penetrate bone surface. So then here we'll have to correlate with X-rays as well. And only a small number of studies have been examined to show how USG can be integrated in the process of diagnosis for inflammatory arthritis. And plus, we also have to be aware of findings and application. Critical analysis: it is subject to availability of USG machine at the point of care. Trained hands and eyes are required. Machine setup for sensitivity for vascularity needs to be explained. Standard criteria for diagnosis are yet to be included in various classifications. So the take-home message is biologic targeted therapies. Now, nowadays we have targeted therapies. So these mandate the differentiation between different arthritis, especially when the other pictures are ambiguous. So USG helps there. USG is already an essential part of early identification and differentiation, and has been included in ACR EULAR criteria. Detection of subcutaneous deposits of tophi. It is a moment of realization in patients who have been coming again and again with episodic arthralgia and are seronegative. And USG is a valuable tool in evaluating patients with arthralgia who have sparse clinical signs. Thank you.
Thank you, Dr. Namrata. So now, you have any questions, anybody, please put in the chat box. And Dr. Namrata, Dr. Sasmit, if you have any questions or any comments, you can ask. Both the faculties are here. Dr. Aneesa, Dr. Akhil, if you want to make any comments, the floor is open for discussion.
Ma'am, one question I had. Actually, any patient who comes to you with this acute synovitis, so what all interventions do you do for them, and how much percentage of relief and duration of relief do they actually have after the intervention?
So, intervention means you mean aspiration or injection of the joints, or yeah. So, very frankly, when I was training, our intervention was very high. So, especially in the UK, literally every clinic we were injecting some joints or the other, especially in those patients who, say, for example, had polyarticular RA, otherwise very well controlled, but say only one knee is giving them trouble. So rather than escalate the immunosuppression, we used to, aspirate, inject the knee. Nowadays, because of the variety of immunomodulation available, these things are reducing. But even then, depending on the patient, if we didn't want to step up their systemic immunosuppression, and it was a single joint troubling them or with low-grade inflammation, then maybe aspiration injection would be considerable. Or other than that, I think in patients who have maybe more of mechanical pain, and those cases, and if we see that serologically their inflammatory markers are not very high, and we are not very keen on raising the immunomodulation, maybe in those patients we would consider intervention. But overall, these days, we first, as we discussed earlier, first and foremost, we would try and identify whether we are missing a patient and they're actually not in remission, they have ongoing disease. Then it's much better that we optimize their immunomodulation. That would still be the first approach. I think one of the takeaway points from the last lecture was very important was the last paper was that it's very important to use ultrasound in all modalities to understand that what are we classifying the disease. Sometimes what happens is we get stuck on methotrexate or the first line DMARDs, methotrexate, sulfasalazine, and then we don't know which direction to go to, whether we are stepping up to biologics, anti-TNF, or whether we have to go to rituximab or tofacitinib. So the choice of this will really depend upon how are we classifying the disease, especially if the patient is seronegative. So in these cases, this ultrasound will really help, because saying whether a patient has rheumatoid, seronegative rheumatoid, or to say whether a patient has a psoriatic spondyloarthropathy, your choice of immunomodulation will really be the key in better outcome. So I think the last lecture especially was a really important one. And for example, if a patient has PMR, no matter what you do, whether you give them methotrexate or sulfasalazine, they will not improve unless they do need to be treated with steroids. So in these kind of cases, just labeling it as undifferentiated inflammatory arthritis would not be enough. That is where the diagnosis becomes very important.
So I agree with you also, ma'am, because earlier we used to do just interventions, and then over the years we have changed our practice to doing a musculoskeletal ultrasound scanning before doing the interventions, and then we realized that maybe it would not require an intervention as such, and the patient usually they come back again and again for the interventions because it is something which gives them extreme relief, immediate relief. I think that is
Yeah.
not justified as well on our end as well. So you can hold back the interventions as much as you can, even whether it is intraarticular or even oral glucocorticoids. And even the guidelines say that. And so we have stopped doing interventions unless and until specific criteria, which I've set for myself, that if there is a monoarthritis, if multiple joints are not involved, look at the severity, look at the synovial hypertrophy, how much is it? And if the patient is in severe pain, monoarthritis, then go for it, maybe.
Absolutely. Or if you're just buying some time for some other reason that you can't, for there's some reason there's a contraindication of giving systemic immunosuppression, maybe then in those rare instances, interventions help. But at least my need for interventions has dramatically reduced nowadays, because many medicines are also now cheaper and they're available more easily. So more and more we are not using as much. But like I said, there will be those instances which still require it, where it's very helpful also. Um, but the point is that, say you aspirate, inject one knee, and then tomorrow the other knee flares up, patient will not be very happy. So that's why I think systemic, especially you have a confirmed inflammatory disorder, then it's much better to optimize their therapy. And I completely agree, not with oral steroids, with a better immunomodulatory agent.
Great. I think, do you have any question, Dr. Namrata or Dr. Sasmit?
One question I wanted to ask, ma'am. Ma'am, in
Sure.
cases where there is unilateral, a single joint involvement of gout, like most of the people when they undergo an episode of dehydration, severe dehydration, the gout gets precipitated, and they
Yeah.
land in severe pain, not responding to any medications at all, like immediately. So
Yeah.
for 3-4 days, I have a few surgeon patients who are like standing all day. So they are not relieved by any medication. So when do you suggest that actually we should give them intraarticular or just medicines and give them definitive therapy, or if seronegative, like uric acid is also not enough to diagnose them, but recurrent
So
attacks?
firstly in this kind of patient, I would first confirm whether they have gout. Because what happens is that, especially in a monoarticular joint, in a monoarticular presentation, with a high uric acid, many a times, we label the patient as gout and start them on urate lowering therapy, and they don't get better. Correct? So then we need to question the diagnosis: is it really gout? Because it could still be any other form of inflammatory arthritis. Many a times I've seen that it's a seronegative spondyloarthropathy. Psoriatic arthritis, especially initially, might come with the first MTP presentation. So it looks very much like gout, and it's very difficult to distinguish the two. But then down the line, they evolve into, multiple joints. So gout is very, very specific. It is episodic. It comes with an attack. It lasts for a few days and then it gets better, even if you don't do anything. So if a patient has persistent inflammation of the joints, despite giving adequate anti-inflammatories, adequate medicines, and if it's not getting better, firstly we should look for another diagnosis. Secondly, if we are convinced that it is gout, then there are a few important things to remember. That very rare cases will, they will not get better with your standard anti-inflammatories, and then you might consider injecting the joint. In a gout patient, still I think it's more justified. And at the same time, combine it with the urate lowering therapy. Now, febuxostat is very, very widely used in India, but honestly, we still prefer allopurinol. Because it gives you wider titration. So allopurinol dose ranges from 100 to 900 milligram. And the idea is to get the uric acid below 6. Until you get the uric acid below 6, you will keep on getting attacks of gout. So febuxostat, I feel, is not a great agent. Doesn't give you so much titrating capacity. I would always start with Xyloric, allopurinol, sorry, along with colchicine, so that you have a period during which the urate, when it's lowering, you might get attacks of gout. So to help the patient, you always combine allopurinol and colchicine. This generally tends to help. And despite all this, if patient is not getting better, then either you can consider, doing intervention, or you can consider again relooking at the diagnosis. Yeah.
Yes, because
That would
most of
be.
the times they are diagnosed outside, like they go to the doctor colleagues and then for the pain they come. So in that
Yeah.
case, sometimes we do inject, but what is your protocol? Like if they have pain, then how many days would you ask them to take the medicines, and then let's see. And does it really get like precipitated with dehydration? Like
Yeah. Sorry, I didn't address that part. You're right. Dehydration is very much a precipitating factor, because the dehydration precipitates your uric acid crystals into the joints, causes inflammation, synovitis. So they have to be counseled upon their lifestyle changes. So not only water intake, but all your dietary things. So despite doing all of that, if the patient is still getting attacks, then it's a bit unusual. There are certain drugs which have not reached India, certain biologic agents which are unfortunately not yet in India. But I think the main thing, like I said, titrate the urate lowering therapy, do all those things in combination, then generally they do tend to get better. It's very unlikely. Then they might be having some other things like other comorbidities, or their creatinine, their renal dysfunction is there, or they are on diuretics. All those things are also, add to it. One more thing which I find helps is adding losartan. That's also urate, it's a uricosuric agent. So that also helps. All these many things are there which you can do in a true gout patient. Which, like I said, main thing is to doubt whether they actually have gout. Yeah.
thank you, ma'am.
Yeah, sure.
Great. So if there are no more questions, I'll just pick up one of the questions which was asked in this thing. This was also regarding, I think, gout only, and somebody asked that what intervention you'll do, but I think this has already been discussed in detail. So you've already answered that question on when we will do the injection and when we'll do give the medication or all that. So I think we are done with the questions. If there are no more questions, we'll now just go to end the session. So anybody, any questions, please come on and just say it now. Okay. Great. I think so. We go on to the end of the session. Thank you all of you for the participation, and especially uh, Dr. Namrata as well as Dr. Sasmit for the presentations. Thank you, Dr. Akhil and Dr. Aneesa, for your kind participation and time. So, yeah, so I think we go on to the end of this session now. This is the season 4 of the Mumbai Pain Schools Pain Journal Club, and this season the focus is on MSK Ultrasound, and we are discussing various ways and means in which we can incorporate this into our practice and how to advance the usage. So this time we had a new time, that is 8 p.m. Indian time on Fridays. We had group topics for seasons. We got 2 faculties, 2 papers, and the papers we've discussed in advance as well. So, guys, for those of you who are here for the first time, just join our mailing list. I have put the link in the chat box. Join the WhatsApp group. If you can't find anything, just mail me at mumbaiPainSchool@gmail.com. I personally monitor this mail and will make sure I answer you. And join us for the next journal club on next Friday at 8 p.m. Also, do look out for our hands-on MIPSs announcement as and when they arrive. And please register and attend this workshop. This time we have a pre-workshop conference as well, and I hope that will be quite effective in all aspects of pain. We're going to holistically deal with all the different aspects and different recent advances of the pain. So with these words, thank you very much. It has been a pleasure having all of you here today. So taking your leave now. Bye-bye.
Thank you, sir.
Thank you. Bye bye.